to us. So just to in exactly in 4 minutes we will start. So sir, Dr. Lakshman, you can stop sharing now.
Okay, sure.
Yeah. Uh, Sir, the flow will be that we will start your presentation. You will start the slides. But this is not a typical lecture, so we will stop at any moment, any time. Any of the welcome, Dr. Navneet Agrawal. So anytime I think I will give signal and I ask some questions and our moderators can ask anything or they can give their comments anytime. So this is how we proceed. And then at the end, I think, or in the meantime also, if we get some questions in the chat box, Mac will be posting that. So we will go on answering all that at the same time.
Oh, sure. We'll do it.
Yeah, fine, sir. So Navneet Agrawal, how are you, sir?
All good, sir. Thank you. Thanks for making me part of this.
Yeah, yeah, yeah.
Please,
Thank you,
please
thank
give
you.
me. I'm
Yeah,
good, sir. आप कैसे हैं?
हम लोग ठीक है सर. This is fine.
Good. Thank you.
Our president has also joined today.
Yeah. Good evening, sir.
Good
Dr.
evening,
B.
all.
Vishwanathan. Yeah.
Good evening, sir.
Dr. Anil Kumar has also joined. I think he has lots of interest in genetic tests and many other things. Mayank, you are ready?
Yes, sir. Yeah.
Yeah, so you have got the PPT slides?
Yes, sir. Yes, sir.
Yes, ठीक है. Dr. Jethmani has not joined now.
No,
Yeah.
not yet, sir.
Anyway, I will start. No issue at all. Yeah, Dr. Pratap Jethwani has joined. Dr. Pratap?
Good evening, everyone. Good evening,
Yeah,
Dr.
good
NK.
evening, good
Sir.
evening. Good evening. So
Good
now
evening.
you have joined. So
Good
no,
evening, Vijay sir. Good evening. Good
yeah,
evening, all the panelists.
yeah. So we will start, Dr. Jethwani, as usual. So you
Yes,
will,
yes.
I think I will welcome, then you will just narrate all the speakers, sorry, moderators PPT, CB slides. And Dr. Khushbu, then you can invite for our esteemed speaker today. The CV slides will be displayed. So that's
So
fine.
I'll start with Dr. Sundaram and then I will
No, we will tell you
also.
okay, when to start for you. First, we
So
will, yeah, Dr. Jethwani will introduce
I
you.
will invite all the panelists and then I will hand over to you, Dr. Khushbu. Then you have to introduce the case presenter and he will start presenting the case.
Yeah.
Okay. Sure.
Yeah, so Mayank, start. Mayank,
Yes, sir. Yes, sir.
give the signal.
We are live now, sir.
Yeah. Dr. Jethwani?
Good evening, everyone. Welcome to this new episode of RSSDI case files, and we are back with an interesting case of diabetes. And we will learn a lot about this newer thing in this episode. So I will first hand over to Dr. NK Singh to introduce our panelists, and then we will proceed with the today's case files. Before we proceed, I also welcome our president, Dr. Vijay Vishwanathan, for this episode of case files, and will look to have his view about this case also.
Yeah, thank you, Dr. Pratap Jethwani. So I think today we are going to have the episode number 27. And as you see, the today's heading is quite interesting. So Dr. Lakshmanan has given a very catchy heading, that is the missing 5. So this is, let us see what is that. And with that, first I have great pleasure that our esteemed President Dr. Biju Viswanathan has joined today. But he has got some throat problem, so I will not take much of his time, or I will not ask any much comments from him. But anyway, so first I just introduce Dr. Khushbu Agrawal. She is MD General Medicine DM Endo, Assistant Professor at Department of Endo at the CMC Vellore, ESI Task Force Obesity, PCOS Skeletal Health. You can see here he is awarded the Yutarna 2025, awarded Best Research Awards also, winner of ISBMR grant and multiple national and international publications. So next, Mank. Again, we have great pleasure in introducing Dr. R. Anil Kumar, Professor and HOD of Diabetes and Endo at Karnataka Institute of Endo and Chairman 2017 to 2018 RSSDI Karnataka. He remained also Secretary of the RSSDI Karnataka. I think he has lots of credentials, 30 original research, and so many things. So I think our all esteemed audience, I welcome you that you know him very well. And then I also welcome and here Mank next one, Dr. Navneet Agrawal. He is the Chief Diabetologist and Director, Diabetes, Obesity and Thyroid Center, Gwalior, and CEO, Beto Sugar Clinics, Visiting Professor, Faculty of Medical Sciences, Vikranta University, Gwalior, Academic Director for MRCP UK at Link Hospital, Gwalior, faculties of regional faculty of so many courses, and also for faculty for IDF, editor and reviewer of various national and international journals, and 120 papers in national and international journals, lots of awards. So welcome you, sir. And now I request Dr. Khushbu Agrawal to
Thank you.
introduce our speaker. Yeah, Dr. Khushbu Agrawal.
Thank you, sir, for such a kind introduction. It gives me, I'm extremely honored to be a part of RSSDI case files, which we have been seeing for a long period of time. And today's speaker is on a very interesting case. It gives me great pleasure to welcome Dr. S.S. Lakshmanan. He is a managing director of Priya Nursing Home in Chennai, and he has been a wonderful student and contributor in medical field right from his MBBS days. He was also awarded Master Teacher Award in 2003 and Lifetime Achievement Award by the Tamil Nadu MGR University in 2012. He's received multiple orations, including the esteemed PG Mehta oration, and he is a teacher to many students in the field of medicine as well as diabetology. We welcome you, sir.
Yes, sir. You know, you can share the screen.
Yeah.
Fine, sir. You can continue.
Thank you, Dr. N.K. Singh. I also thank Vijay Vishwanathan, Pratap Jetwani, Dr. Anil Kumar, Dr. Khushbu Agarwal, and Anil Kumar. I think a very interesting case what I had received this year, which I presented to a few forums also. This boy is a 13-year-old a vegetarian boy from North India, Marwadi boy. He was admitted with a high fever and abdominal pain and continuous vomiting of 3 days duration. He is a known case of type 1 diabetes on basal bolus insulin regimens since 2 years from 2023. He was evaluated for abdominal pain in the year 2023 and found to have a hydronephrosis left kidney with elevated blood sugar of 600 milligrams at a corporate hospital and was shifted to a specialty hospital for sugar control before surgery. He was treated with insulin therapy, then was investigated, diagnosed as a type 1 diabetes. There was the hospital report on 2023, the A1C was 17.5 at time of admission. and the C-peptide was negligible. And the postprandial C-peptide again is only 2 piconomoles, suggesting almost no C-peptide activity. The GAD antibodies were, however, negative.
Yeah, I think Dr. Lakshman, I think let us stop here. So I think you can go to the first slide. So I think this was the, yeah, so you have got a clinical presentation here with the vegetarian and Marwari boy. So what was the significance of showing that? The vegetarian and this Marwari boy, anything you are thinking relevant?
I only said these dietary habits. He's not non-vegetarian.
Yeah.
He's from North India, probably taking more of wheat-based diet than the rice-based diet.
Mm-hmm.
That's number 2.
Mm-hmm. So, yeah, so Dr. Navneet Agrawal, so do you think that you should ask more and more history and add anything more here?
Yeah, so like if we think first, like Sir has asked already, the vegetarian, non-vegetarian, but like Marwadi boy, so we should understand like which Marwadi clan, or like if you're suspecting anything genetics or anything familial, so then we can ask for any the family history, or like we can understand like which Marwadi or which say special like the like, because like we see that some genetic disorders are more common in some say caste, or we can say some clans.
Yeah.
So vegetarian,
So
yes,
that,
though there are people are eating more of the cereal based diet or the wheat based diet, but I think that is not a very evidence, or that is not, that will not suggest something that we can make some diagnosis or make something clear in our mind.
Dr. Anil Kumar, so I think I don't find any family history tree here. So,
Family
so
history.
whether Dr. Lakshman is going to show that, or
Yeah, I'll show you that. I'll show the history.
that you will show. So, Dr. Anil Kumar, your comment at this time.
And also 13 years school student presented with high fever, abdominal pain, and continuous vomiting. He said known case of type 1 diabetes. Since how many years it was diagnosed? Because age of onset of
2 years.
diabetes is very important.
He was diagnosed at the age of 11 years, 2 years back.
11 years. So 2 years back he was diagnosed. So you said type 1 diabetes, whether they have done any investigations before to prove that it is type 1 diabetes.
I'm showing you a few slides. You can I'll go through.
Can
first
I say
thing.
something?
Yeah,
Yes,
sure.
ma'am. Yes,
Sure.
ma'am. Yes.
Yeah, while the first presentation, he's having abdominal pain and vomiting. Sir has shown in the next slide that the GAD is negative. So while he's a young boy, um, uh, pancreatic diabetes is also one of the differentials because ketosis is negative, and with such high blood glucose values, which we normally see in these patients, they do come with, like, this episode could easily be an episode of pancreatitis because he's having pain, abdomen, and vomiting.
No, he
So,
had a severe ketosis.
okay.
Okay. Yeah, so you go to next slide, sir.
Yeah. This is the one, no? He had
Yeah.
referred from a corporate hospital for surgery for hydronephrosis. He was found to have 600 milligrams blood sugar, so he was referred back to the specialty hospital for diabetes. And there, the investigations they done, they said it's a case of type 1 diabetes because the A1C is 17.5 and the C-peptide is
So
almost.
back, I think again, I will just a bit more question about this history. Dr. Jethwani, do you think there is a history of hydronephrosis? So whether this history is important or not?
I think I would like to ask 2 questions first.
Yeah.
Whether he was presented with ketosis at first incidence or not, because you are mentioning only blood sugar, and then he was referred to diabetes clinic for management of sugar. So whether he was presented with ketosis or not.
Yeah, I'll show you the discharge summary.
Okay. And
Okay,
second,
sir.
the C-peptide which was done, it was done when the sugar was more than 600, or first the sugars were controlled and then the C-peptide was done?
It's all at the same time. The same day.
Because it will be difficult, because with such high sugar, there is going to be some glucotoxicity, and C-peptide is going to be less, but
Suppress.
here it is negligible. But
Yeah.
still, I would like to ask all the panelists whether it is justified to do C-peptide with such high sugar, or first correct ketosis and before discharge do C-peptide and other things for final diagnosis or stamping the diagnosis as type 1.
Yeah, this is
What is the
important
view of
question.
panelists?
Yeah, so Dr. Agarwal, what's your opinion?
So there are two Agarwals.
Yeah.
Yes.
So you can proceed, Dr. Kushal. Like, but yes, Dr. Jethwani has rightly pointed out that ideally we should not get the C-peptide done when we have a very high blood glucose values. Ideally, we should correct it because of the glucotoxicity, we might misdiagnose them as a lower C-peptide, particularly for the patients when it is a borderline sort of. So better we should correct it and then we should go for a C-peptide level done.
Fine.
I do not know whether you get a negligible C-peptide in even a glucotoxicity.
That is, I think that is quite rare. But
That is
still,
quite rare, and that
One point regarding C-peptide, of course, if we do C-peptide at, of course, blood sugar at a higher level, probably in some of our patients, as he said, negligible C-peptide. When there is negligible or almost, we say 0.001. In such instances, probably we can think that it is type 1 diabetes. And maybe we have to repeat C-peptide
Yes.
when the blood glucose is
Yes.
controlled.
yes,
That's what I feel, because some people say you should not do C-peptide when the blood sugar is high. So this is true in case of type 2 diabetes. When it comes to type 1 diabetes, when the C-peptide is very low, as in this case, probably there may not be any increase of C-peptide even after correcting the glucotoxicity. That's what we have seen in some of our cases also. And he said stimulated C-peptide some 0.2 picomoles. That is also very negligible.
very low.
And of course, one of the algorithm, what we say, less than 0.6 nanograms or less than 0.2 nanomoles, we should think more in favor of type 1 diabetes. If it is between 0.6 to 1.5 nanograms fasting C-peptide, it could be either type 1 or type 2 diabetes. If it is more than 1.5, definitely it should be type 2 diabetes. So that's one algorithm I think we can follow. Maybe clinically it is very important, especially when we differentiate between type 1 and type 2. Now type 2 has become more common than type 1 in young generation. We have seen most of our cases. So in that aspect, maybe C-peptide will help, but we can do serial levels of C-peptide. And just I wanted to know whether these patients, 2 years during that time, whether they have done C-peptide levels.
Yeah, we'll see a lot of slides information.
okay.
Coming. Thank you, Dr. Anil. I think the patient's profile is high sugar and then almost nil C-peptide. The GAD is negative. So there's no GAD antibodies. I do not know whether does it rule out type 1 diabetes or can also have GAD negative.
No.
Again, here we have to think that there is type 1 autoimmune and type 1 idiopathic.
Yeah,
So this could be type 1 idiopathic.
Yeah.
And we have seen so many cases, GAD negative, but having very low C-peptide levels, they turn out to be type 1 diabetes. That is especially common in some countries like African countries. They see more of type 1 without antibodies. Even in India also, maybe we can say 10 to 20% of the cases, it will be negative. So in that aspect, still we cannot rule out type 1.
Yeah.
May I ask one question to Dr. Khushbu?
Yes,
Yeah.
sir.
She is from CMC Vellore. So
Yes, sir.
what is the general spectrum of antibody profile in type 1 in our country?
Sir, we actually deal with adults usually. So by the time they come to us, we have patients with GAD positivity because we see them even if they're in childhood diabetic, we see them after they're 15 years old. So in our profile, in our practice, mostly patients have GAD that is positive. But in our country, in children, ZNTA and IA2 are also, there's a huge number that is positive. So it's important, just because GAD is negative, that doesn't rule out type 1 diabetes because he's a 13-year-old boy and only 2 years into diabetes. So definitely other antibodies should be done to rule out type 1 diabetes. So
Yeah.
Thank you, Dr. Khushbu.
thank you, sir.
Next slide, I think you see the diagnosis here, the type 1 diabetes with diabetic ketosis. That was the year 2023. So very classically, this boy presents abdominal pain, high blood sugar, ketones positive, negative C-peptide, and negative GAD antibodies. And he was treated with the basal bolus insulin. You can see he's on a regular insulin of 15 units 3 times a day and 25 units of basal insulin, glargine biosimilar at bedtime. 16/7/23. Now, after 5 days, still sugar has not come down. The doctor updated the regular insulin to 18, 20, 20, 18, 20, 18, 3 times a day, and 25 units of glargine insulin at bedtime, and declared him fit for surgery. Any doubts till this time?
I
What
think
was-
in your diagnosis, everything so far fits okay, but just doing only one antibody, GAD antibody, because lots of insulin antibodies are there. Sometimes we get GAD negative, but other antibodies, insulin antibodies are positive. So in this case, I think that we are not done.
Yeah. We're not
And
doing zinc transporter.
so far, we have not given a family history in detail.
Yeah, I'll give you that. It was not given when after my admission in the hospital, I'll give you that. Now
Yeah.
he is referred for the urologist again. So this boy underwent on 3/8/23, the 1 week after the discharge from the diabetic hospital. He underwent left kidney pyeloplasty with a basal bolus insulin regimen. It was stented once. The stent came out and repeat stenting was done after 3 months later. Now, after 22 months, we do not know what has happened between these 22 months. He probably has been visiting the previous hospital or is taking the same insulin dose. He presented at Priya Nursing Home with diabetic ketoacidosis with urosepsis. On examination, this guy was really febrile, toxic, severe dehydration, and temperature was under 3.2, pulse rate was 132, respiratory rates were 30. He was actually very emaciated, very lean. BMI was less than 18. Weight was 36 kilograms. Abdomen showed severe left loin tenderness. Absolutely no markers of insulin resistance on the skin surface. Past history of operated for left tongue hydronephrosis and the TJ stented device in 2 years' time, both at a corporate hospital. And there's no family history of diabetes, nothing in the 3 generations. Nobody is a diabetic. His father and mother, they're all damn healthy. This is the presentation in the hospital in my setup. Now the random blood sugar was 620 milligrams. The A1C was 16.8. Urine was dense with ketones. It also showed a lot of pus cells with RBCs. His USCR was positive. Urea was raised, 56 milligrams. Creatinine was 1.4. Sodium was 138. Slight rise in potassium, 5.4. Chloride was 98. LFT and thyroid functions were normal. You can see the enormous rise in the total count, 32,000 with the polymorphs of 84, and the CRP was 130 milligrams per liter. Chest X-ray was normal. ECG showed a sinus tachycardia. Echo, there's no LV dysfunction. Scan abdomen showed a residual hydronephrosis left with a severe perinephric fat. It's a fat flare which suggestive of acute pyelonephritis. Serum hydroxybutyrate was positive. The initial diagnosis was diabetic ketosis with a UTI with the pyelonephritis left, shifted to ICU.
Yeah, Dr. Lakshman, we have got 3 questions now. Dr. Khushbu Agarwal, can you see in the chat box?
Yes, sir.
So can
So
you ask? Yeah.
the first question Dr. Parthasarthi is asking, were antibody testing done beyond GAD to consider clarify the etiology of diabetes, like IA2, ZNTA, ICA, any of these antibodies?
Nothing. It's not done in the previous hospital.
Okay. The second question is, I think, already asked, but he's like, how do we, Dr. Subhashis is asking, how do we interpret a Marwari vegetarian child with this profile? Does ethnicity or diet play a role in modifying a role in phenotype?
I don't know. I referred to literature. There's nothing specific was there in anecdote with the genetic problems with the diabetes in Marwari people.
So Dr. Anil Kumar, can you give them any other comment on that? Yeah, Dr. Anil.
Now, the main this thing is he has infection, the UTI with pyelonephritis and diabetic ketoacidosis. So this is again, I think, the second episode of diabetic ketoacidosis or is it because 2 years before, whether he had any episode of ketosis like this?
Yeah, first time now before surgery,
Yeah.
first hospital.
And also whether at the onset, whether he presented with ketosis or he had any symptoms, because
The
2 years
first
back,
admission was in a we went for a ultrasound, showed a iron forces, referred to a hospital for surgery, where they found out the boy has got a highly elevated blood sugar, referred back to a diabetic hospital. There was made a diagnosis of diabetic ketosis with type 1 diabetes.
I think this is the second episode of ketosis.
Second episode of ketosis.
Sir, I would like to point out that this boy has had a very poor control. In the first discharge summary that sir shared from the previous one, his weight was 48 kilograms. And the weight
36.
in this one is 36 kilograms. So, on known case of diabetes on basal bolus regimen has lost 12 kgs of weight. So, that tells that historically this boy never had a good control. And interestingly, first summary also mentioned ketosis, and sir has also written ketosis in a background of urinary tract infection. None of them have mentioned acidosis. So probable it is in ketosis is because of sepsis. Like that's a confounding factor over here.
You like to say starvation ketosis?
Um, I would say that in absence of acidosis, type 1 diabetes is, I am less likely to say that in such severe, like he's having blood glucose of more than 600 milligram per deciliter and he does not have.
Common, isn't it? When you have high blood sugar and ketones, it's prudent to put the problem to diabetes rather than something else.
Yes.
Whether ABG was done?
Now,
May I
ABG was
ask one
done, but
question?
I've not shown the slide. ABG
Yeah.
again showed a classical metabolic acidosis.
At the time of discharge last time, when he was diagnosed first time, I think he was discharged on around 75 to 80 units of insulin.
Yeah.
And his body weight was only 48 kg.
Yeah.
So I think in type 1, generally that much insulin requirement is quite initial. After recovery from DK, it may be there for a few weeks, but otherwise then they settle down around 0.8 to 1 units per kg body weight per day, not this 1.5 units per kg body weight per day, because his
I think
body
let me
weight
complete
was
a few
50.
more slides, doctor, and then we'll discuss the case entirely.
Yeah,
Okay, fine.
Yeah.
That will be
But I
nice.
think here we got
Okay.
more 3 questions.
Yeah.
Because
Yeah.
3 more questions are there.
We'll take it later.
Okay, no, sir.
Yes,
You
yes,
can, you
yes,
can
fine.
proceed. Yeah.
We started the patient in ICU with the IV insulin therapy. He was on 5 to 10 units of IV insulin every hour to almost 150 units per day to keep the blood sugar less than 180. He was also given a corrected dose of meropenem for the renal thing. IV saline and started standard care for diabetic ketosis for a few days in the ICU. His RFT became normal. The boy also recovered. After shifting to the ward, he needed the rapid-acting aspart insulin, 18 units 3 times a day. The biosimilar, the Tresiba insulin is 30 units at bedtime, just to keep the blood sugar between 180 to 240. It's very difficult to bring down the blood sugar less than 180 at a given time. I advise the patients, parents, we can't go for a insulin pump, because the boy was very, very crying for 4 times insulin and a number of times pricking of his blood sugar levels. And it was very difficult to bring down the blood sugar below 180 milligrams. Now the problem is almost 4 times he got record of sugar 600, diabetic ketosis 2 times, pyeloplasty left kidney once, DJ stenting twice, recurrent UTI, needed a large dose of insulin and still the sugar not under control. The pump is the only solution in this patient. Or are we missing the diagnosis? These twins, they look similar. Do you have any other diagnosis for this boy? Are you missing as a physician? I somehow managed to get the boy some samples of insulin because they are not very, very rich. They could not buy analog insulins. I could get them few samples of insulin. After 1 month, we repeated the GAD antibodies. C-peptide, both fasting and stimulator were done. Again, the GAD antibodies were negative. And C-peptide, there was some evidence that the C-peptide was slightly came 0.6 nanogram and stimulator was 0.9 nanograms. We are not sure what exactly we are now dealing with, unsure, puzzled, lost, confused, unclear, baffled. Are we missing anything or we are on the right pathway, whether the patient needs only IV insulin therapy in the form of pump? What should be done for this guy?
Yeah, Dr. Navneet,
So,
can you, yeah, you please,
I
they will
went to
discuss
the
a bit.
classification
Yeah,
of diabetes. Yeah, we'll discuss. Then we'll go. Yeah, please.
yeah, Dr. Navneet, your comment at this point.
Sir, seeing the history and seeing the presentation, as Dr. Sundaram has rightly pointed out, that a patient coming with the higher values of the blood glucose, more than 500, 600, with the presence of ketones and that too higher ketones, and a significant weight loss along with this much of insulin therapy. Probably at this point of time, yes, everyone like who's sitting in the OPD, sitting in the clinics or the hospitals will go with the diagnosis of type 1 diabetes. Seeing even the C-peptide, which has come after even the blood glucose values have come down to 200. But as Dr. Pratap Jetwani was saying that in spite of this much of like around 150 units of insulin a day, the boy is still uncontrolled. The A1C, like he was also using like almost more around 100 units in a day, and the A1C has come down from only from 17 to 16 in 2 years. So that was worrisome that yes, why he's needing that much of insulin therapy, why, and he's losing weight. That means the catabolism is there, and in spite of using that much of insulin, there is no evidence of weight gain or no evidence of improvement. So we should reconsider, we should think that why the insulin is not working and what is the problem.
Yeah, so Dr. Anil Kumar.
Hello, as the main point is the insulin, high dose of insulin, what he is requiring. Maybe 150 units of insulin is requiring. And as we said, in spite of that, his weight he has not gained. And in type 1 diabetes, we all know, of course, now here also there were no signs of insulin resistance, even during workup it was shown. But why is requiring? Is it probably because of the infection during the early stages he may require, but still after some time he is requiring the same amount of insulin? Then we have to think, is there anything else other than type 1 diabetes we have to think? And one more, the C-peptide level, which was negligible. Negligible means 0.2 picomole, very low. Now it is 0.6 nanograms per ml. Fasting stimulated has come to 0.9 nanograms. So there is definite improvement of C-peptide with correction of glucotoxicity. So here definitely we should think of something else other than type 1 diabetes.
So yeah, that's a very illuminating point. So I think still Dr. Sundaram, if you ask me, I will again go for detailed history. So for the family history, so you have not, now I can reveal now.
Probably we are missing family history. Maybe father and mother who are not having, or grandfather, grandmother, then we have to have a detailed family history, or we have to ask
There's perfectly no family history of diabetes. Because both grandfathers, my grandmother also in Chennai. We checked everybody's blood sugar, it is normal.
Yeah, so yeah, Khushbu.
Okay, I'll go. Yeah,
There are 3 more questions in the chat box, sir.
please.
So Dr. Ilavarasi is asking, could hydronephrosis or a prior illness may have triggered or unmasked the diabetes? Is that the thought process here?
We do not know. Hydronephrosis is congenital, that we know. Because he underwent Anderson-Heinz, then followed by stenting.
The second question is by Dr. Prafullata. She's asking whether there is any evidence of honeymoon phase post-diagnosis. No, we haven't been able to control at all. Or did the insulin requirement consistently remain high? So,
Yeah.
sir just told us that it was more than 150 units. Then we have another question. Dr. Natarajan asked, was there any nutrition challenge in managing the insulin carb balance because the patient is vegetarian?
We do not know. We tell the patient the correct diet. We have got a dietitian to tell us what Nardinas they take. They take the history, give the proper diet advice. We also gave good protein medications to the boy. I think despite all that, the boy was not recovering. So I will follow the slides again. Okay.
Yes,
Yeah.
yes, yes.
So I went
Go
back
ahead,
to the
please.
classification of diabetes because you should be one of these 5 types. It cannot go anything beyond that. Type 1, as we, in this case, is it a type 2 diabetes? I don't think the boy is not obese. Is there any specific type of diabetes, like somebody said FCPD, pancreatitis, some endocrine causes, or a type of monogenic syndromes? It is not gestational. And I was attending the Bangkok meeting where they brought out the type 5 diabetes this year, April 8th. I think Singh was there. They say malnutrition related diabetes now has been officially recognized as type 5 diabetes on April 8th, 2025 at IDF Bangkok. First case is 1955, but we see a lot of cases in India. BMI less than 19, very high blood glucose, need always insulin, but they say there's no need for it. There's no ketonuria reported in
One more point I want to make.
Yeah.
That type 5 diabetes will not require such high dose of insulin. They
Yeah.
require very low dose of insulin. That is
Okay.
one of the important points to differentiate between type 1 and type 5 or malnutrition related diabetes.
So this case belongs to a type 5 diabetes. There's
No.
question mark. I sent the blood sample of the boy and parents for precision diagnosis and waited for 8 weeks. This I could make my friend to do it in a very concessional rate, and the results came. Any guess from the learned chairpersons?
I can only guess that although I have
Saying you cannot
some idea.
know the case.
Yeah, I know the case anyway. Then like Khushbu also knows the case, and that Anil Kumar. So that Anil Kumar, you don't know the case. Can you guess anything?
Maybe as there is renal involvement, this probably if you can, because again, if you consider monogenic diabetes, we can say HNF1 beta. But again, the negative point is there is no family history. Family history is totally negative. So that except for the association of renal abnormalities, maybe we have to see even HNF1 beta requires insulin. It will not be controlled by any other OHs. They require insulin. And
So sir, really you have given a very important input, but still there are lots of issues in this case. So now that Navneet, any idea?
Sir, as like we are suspecting that this patient is first thing is that it is only anti-GAD negative. We have not checked for the another antibody. So still we have the option on mind of type 1. But the thing is that patient is not responding to this much of high therapy. That means we might be having some genetic disease or some like monogenic, as Dr. Sundana was saying. Yes, that is a chance. And as like Anil Kumar sir was saying that there is no strong family or no family history like in the 2 generation, 3 generation. For diagnosing any MODY, we always ask as a clinician, as in the clinics, we ask for the family history that it should be in 3 generations in the like autosomal dominant. But there are some forms of MODY which are like we can say idiopathic mutation, not the genetic inheritance, wherein we can suspect this type of a patient in that category where it has a spontaneous mutation rather than a inheritance.
And I would just like to point out that I agree with Anil sir that that sir picked up very nicely that C-peptide has improved after a good control. So maybe not enough, but there is definitely some beta cell action that is persisting. So that is a very, very interesting point. So, but don't know what you're dealing with.
That small amount of rice, one made me to suspect to go further in this case. As you rightly pointed out, why should some beta cells still function if you suspect a type 1 diabetes? Now the results came. Mohan wrote, Dr. Lakshmanan, congratulations on picking up HNF beta MODY 5 with regards. In fact, the parents were again checked for the genetic deformation. It was negative. This is the one referring to all of us, the Tattersall-Bajans criteria, which came in the year 1975. These criteria were helpful but not specific enough to definitely diagnose MODY, but often used in conjunction with other diagnostic methods such as genetic testing. Of course, for the clinicians, somebody has got early diabetes less than 25 years of age, a family history of diabetes and at least 2 to 3 generations. They don't require insulin initially. Absence of obesity and obesity markers, the external markers of insulin resistance. But of course, they mentioned that they don't have a ketoacidosis.
The major.
Dr. Lakshman, yeah, wait here.
Yeah.
Can you go to back slide? So at this point, I think you just started your treatment and you sent for the genetic test. So what exactly prompted you to do so fast?
Somebody pointed out why should the C peptide should get stimulated. There is some source some insulin is coming out, stimulated again is going up slightly, and it's not responding to the insulin. We know that the guys, MODY children, they do not respond to insulin. Once you put them on sulfonylurea metformin, the requirement comes. I've seen some of these children put on so much of insulin as type 1 diabetes, but they turn out to be type 2 diabetics. All these things made me to think that this case
so that was the catching point that you did a very early diagnosis of this case. So, Dr. Khosbu, there are 3 questions. Can we discuss now again? That will be better.
So Dr. Pichai asked, despite repeated negative GAD antibodies and very low but not absent C-peptide, what is the best way to classify this patient before the genetic testing? So is it autoimmune type 1? Is it ketosis prone diabetes? Is it idiopathic type 1B diabetes? Or is it malnutrition type 5 diabetes? Fastest finger first. So out of the 4 options, which option should we choose?
So now if all the antibodies are being done, if it is negative, we can say it is idiopathic type 1 diabetes. Because there is only one antibody, GAD antibodies, we cannot totally rule out it is not autoimmune. So that is one. But we cannot say it is type 5. Type 5 is ruled out with very high dose of insulin. And then ketosis prone diabetes. Again, ketosis prone diabetes have different features. Without infection, they may precipitate ketosis, and it is in a selected population. But again, C-peptide levels, we have seen even in ketosis prone diabetes, fasting and stimulated will be higher. We have not seen very low C-peptide levels. And of course, we have that is A plus beta minus, A plus beta plus, that classification is there. But still, it is very difficult. I think it should be idiopathic type 1 if all the other antibodies are negative. Maybe ketosis prone, still we have to have some more points to say whether it is ketosis prone. That is before the genetic analysis.
Dr. Shobhavati asks, could his chronic renal disease, recurrent infections and malnutrition be confounding factors in interpretation of C-peptide and insulin requirement?
So, yeah, Dr. Mayank, the Dr. Agarwal.
Navneet sir.
Navneet? Yeah.
Yeah, sorry.
Yeah.
The question is the chronic infection, renal disease and malnutrition be confounding factors in interpretation of C-peptide and insulin requirement?
Yes, but like if the infection is persistent, because I don't think that patient might go with the septicemia for a long.
Yeah.
Like he's having a TLC of 32,000. He can't go for this much of septicemia for months or years. So ideally, if it would have been because of the infection, the insulin requirement should have come down, as we see in our clinical practice.
You remember, in my case, I've done the C-peptide and the GAD only after 1 month of treatment.
That's what I'm saying. So like if the infection has gone, ideally this requirement should have gone down.
That's why, as you all rightly said, during severe hyperglycemia, it's not wise to do the C-peptide. You try to correct it and then try to do the beta cell reserve after some time.
So Dr. George is asking, any adjunctive therapies like metformin, SGLT2 inhibitors, GLP-1 analogs recommended in such cases, or are they unsafe or ineffective?
Yeah,
Currently, the situation needs only insulin. How can you give all those drugs and the patients got symptoms and severe hyperglycemia? They are all.
So in acute cases, no, nothing can be given. The patient's BMI actually rules out the use of GLP-1 analogs. And recurrent infections, urinary tract infections, SGLT2 inhibitors never could have been, they would have been contraindicated anyways. Metformin, I don't think so. There are no features of insulin resistance, so
No features. And
we're not sure.
Shall I
Dr.
proceed
Tang,
with the same?
no, sir, there are two more questions. Dr. Tangavelu asks, should we consider screening the family, parents or siblings for atypical markers of diabetes, given the suspicion of type 5?
This center, people have been screened, both parents are screened for this HNF beta, they're negative. Both the parents were negative.
So Dr. Shanmugam has a very interesting question. With the new idea of recognition of type 5 diabetes in 2025 Bangkok, how do you see this changing the diagnostic algorithm for lean children with insulin-dependent diabetes in Asia?
That's a very good question. That's why I given the analogy how exactly this behaves like, or because they'll be again we have to do the GAD antibodies, C-peptide levels. These people they are called brittle diabetics. They respond to small dose of insulin. The sugar go on high. We will really find it out. These people. It's not a much problem to differentiate. These people are rightly Dr. Anil Kumar said. They don't require so much of insulin.
maybe in future we may see more of such cases. Of course, already we have such cases, but we are not picking up those cases.
Yeah.
So maybe in future we have to see for this type 1 diabetes, especially in India, because of malnutrition, we should see more of type 5 diabetes.
Yes.
Type 5 usually doesn't come in children. It is a process of malnutrition over the period of children, and that usually presents it usually presents in adulthood, according to what my teachers have studied. And one interesting point is that it is usually seen in children who have a history of malnutrition, not just diabetes. So, like patients who are admitted in malnutrition ward in the pediatrics. So, or the people who come from extreme poor background. With history of either marasmus or kwashiorkor, those are the people who are more likely to have type 5 diabetes.
What I remember in my undergrad days, I'm sure sir is senior, like when I was doing my MBBS, this malnutrition related diabetes was mentioned in the pediatric books, and we used to read in that like the pediatric books at that time. This was included in the pediatrics curriculum, MRDM.
Yeah.
May I ask one question? Sir, can you go to the next slide? Criteria. Now, if we see this criteria, I think of this, only one criteria is present in our patient. That is early onset of diabetes. There is no positive history. There is no non-insulin dependence.
Because
rather is requiring very
yeah,
that is what I am asking.
when he
very
was
large doses
there,
of
only
insulin.
few Modi, the common Modis were there. They don't have so many Modis of what we are now 15 types. When Bajans was there, only initially 2 or 3 types of Modi were there.
yeah.
I think even if we go by the Modi calculator, the probability calculator which is available online, most of the calculators, they suggest that if the insulin requirement is less than 0.5 units per kg body weight per day, then you have to think of Modi. If low insulin requirement is there, that is what most of the Modi calculators they suggest. If the insulin requirement is on the very high side, then they suggest probably this may be related to insulin resistance.
I think
and type
I'll
2
go.
diabetes.
I'm going detail into the case. Then you
Yeah,
will
go. Yeah,
understand.
please proceed. Yeah, please proceed.
How bad is his pancreas?
Okay.
Now, this is the type we talk about, the Modi 5, HNF1 beta. The secret is in the gene. Severe kidney disease, pancreatic hyperplasia, female reproductive organ abnormalities. They come under the Modi 5 category. In fact, this is called the RCAD syndrome. renal cyst and diabetes syndrome. As you could see here, the diabetes and renal cyst or renal agenesis, because this particular gene is required also for the epithelial presentation of the both kidney and the genital tract. So they always present with the some other abnormality, mostly in the pancreas. This type of MODY 5. This chromosome is 17q. It's in the HNF1 beta gene in the chromosome 17q. The abnormality was found out. HNF1 beta associated MODY 5 is a rare monogenic form of diabetes caused by mutations of the HNF1 beta gene and the chromosome 17q, often leading to very early onset of diabetes and other multisystemic issues. That's the point I thought I'll. The first case of MODY 5 was reported in only 1997 in a Japanese family. The HNF beta was encoded by a human transcription factor 2 gene, which is expressed in a wide variety of tissues, including the kidney, pancreas, genitourinary epithelium, liver, and lung during embryogenesis. Actually, we have 14 subtypes. I think recently, Dr. Mohan reported the 15th subtype. Among the all MODYs, the MODY 5 accounts less than 5% of the cases. And along with diabetes, it presents with a number of extra pancreatic manifestations, which I thought I'll stress again. Here's a boy who had 11 years old when he presented with the diabetes, renal dysfunction, and obstructive uropathy. And I think Dr. Anil Kumar said the MODY 5 also requires insulin. Type 1 diabetes and MODY 5 share similarities in their early onset, potential for misdiagnosis with type 1 diabetes, and ability to cause similar diabetes-related complications. Despite the rare disease, the MODY 5 is underdiagnosed and often treated for decades as a type 1 diabetes. It should be considered in all patients with diabetes and CKD at a very young age if a family is suggestive of nephropathy, which appears before or after the diagnosis of diabetes, or presence of liver disease, which increases the degree of suspicion. Early diagnosis always allows the risk of complications to be minimized and to carry out the preconception genetic counseling. So HLM MODY 5 should be considered as a multi-system disorder in the differential diagnosis of young patients with renal abnormalities. In fact, the another group of patients where screening of HNF beta will be helpful and can change the management are young patients requiring renal transplantation surgery secondary to morphological renal abnormalities such as renal cyst. So rightly said, it's also called ARCAD syndrome because of the renal cyst and the diabetes syndrome. The MODY 5 was one case as reported in the IJM journal in the year December 2023 by Dr. Prasad, Tirupati Nakendra, and some of the people here. Yeah. Anything?
So in literature, especially in India, how many cases of this HNF1 beta reported?
This is only one I could get.
No, but actually, if I see in Dr. Mohan's group, we have one HNF beta in one of the studies, and also from Vellore also they have reported one HNF1 beta, and even our institute has one HNF1 beta in a pediatric population. Okay. So like that, we have very it is in numbers only, because if we say 5% is definitely huge. Okay. So I think it is very rare. Maybe it is less than maybe 1%, 2% like that. So whether we have any other diabetologists or endocrinologists reporting HNF1 beta other than this, I think we have to search the Indian.
Search. We can find out from the questionnaire, or Encasing can stimulate the audience. He's got diabetic doctors under his care to check up if anyone has reported the HNF1 beta before.
Okay, sir. I will do that. Yeah. I will do that, sir. Yeah.
Now, it's very important. You look at the pathophysiology of HNF beta associated MODY. The pancreatic hyperplasia resulting in beta cell hyperplasia results in decreased insulin secretion with the release and increased hepatic insulin resistance. Despite the small dose of insulin being secreted, there's a resistance to the liver which play a major role in the development of diabetes. Severity of the pancreatic hyperplasia determines the severity of hyperglycemia and possibility of ketoacidosis at initial presentation. So it is inherited as an autosomal dominant mode. However, one of our chairpersons have said the de novo mutations. What has happened in this case? This case is a sporadic case where mutations can sometimes occur de novo in about 50 to 60% of cases. So not every case should have a positivity of the family history. The possible mechanisms of diabetes in mode 5 include reduced insulin secretion, insulin resistance, and abnormal glucose sensing mechanisms. Now come to the important questions. The treatment options through the net. Those sulfonylureas are used as a first choice in mode 5. Its efficacy is comparatively less in mode 5, and patients often require an early insulin therapy. And he said, what happened to some people asked what happened to the use of metformin, pioglitazone, and DPP-4. I want to ask your people, what happened to the alpha cells in mode 5? Chairperson, alpha cells.
Yeah, Dr. Lakshmanan, I think Dr. Khushbu I shared and I think link. Can you just click that link on the chat box? Is it possible?
I can share the.
But he has shared the screen, so Dr. Lakshman, can you just say, or later we can do, yeah, no issue.
Yeah, we can do later.
No.
Yeah, later. So she has presented one case, her own case. So anyway, so treatment option you are asking whether the sulfonylurea is the first choice. Its efficacy is less in type 5, it's MODI 5. So often require an early insulin. So what about metformin, pio, and DPP-4?
Just before that, what happens to alpha cells?
Yeah.
In
So
mode
Dr. Khushbu, what's your opinion here?
We have only one patient. I have managed only one patient, and unfortunately, in my case, the girl actually, because of a recurrent urinary tract infection, had CKD long before she had diabetes. So, because of her CKD, she could not be on anything else without except insulin. So, we never really considered her putting on all of these medications. And going back to what Sir said, that because of the high insulin requirement and this patient requiring more than the actual, like more than 1.5 units per kg of insulin, probably an insulin sensitizer, I would like to give a try, even in absence of any features of insulin resistance. So definitely a trial of metformin and or pioglitazone should be made.
Yeah, I agree that what is the harm in giving metformin here and gliptins? So Dr. Anil Kumar, so what's your view? Because you don't have clear-cut so many cases and so many guidelines here for that.
As pointed out, I think insulin sensitizers is a good option, either metformin or pioglitazone. Maybe initially we can try metformin at a low, probably low dose, maybe 500 mg to start with, and then see the effects. And even pioglitazone at a lower dose can be tried. I think DPP-4 inhibitors may not have much effect or use in this case. So probably metformin and pioglitazone are the good options.
I'll go ahead with the slides.
Yeah.
Now, there's an interesting topic, the alpha cell function in mode 5. In mode 5, which is caused by mutations in the HNF1 beta gene, alpha cell function is often impaired alongside the beta cell dysfunction. While the alpha cells primarily secrete glucagon to raise the blood glucose, they also play a role in maintaining the beta cell health. In mode 5, this intricate balance is disrupted, potentially contributing to variable clinical presentations of the disease. Impaired alpha cell function. The beta cell function is central to the development of diabetes in mode 5. Alpha cell abnormalities also play a role. Alpha cells in mode 5 may not respond properly to glucose levels, leading to abnormal glucagon secretion. This can exacerbate hyperglycemia and high blood sugar characteristics of diabetes. The alpha cell function modified can contribute to exacerbated hyperglycemia. Abnormal glucose secretion can worsen the blood glucose levels, variable clinical presentations, and there is some potential for therapeutic targets. Understanding the role of alpha cells in B-modify opens up potential avenues for developing new therapies that target both alpha and beta cell function. There is a beautiful slide I got from the net. What happens to the HN beta mutation modified? There's a pancreatic hyperplasia, islet cell disorganization, beta cell dysfunction, decreased insulin secretion, hyperglycemia. In alpha cell dysfunction, there's a dysregulated glucagon. In fact, the fasting glucagon levels are quite high. They actually they go up, and the response, decreased response to glucose is not there. So in inappropriate secretion of glucagon, again aggravates the patients to go in for very high blood sugar in cases of modified. What happens to exocrine functions? Because the total pancreatic hyperplasia. So again, the proof is that modified exocrine dysfunction is a significant feature, often manifesting as pancreatic atrophy or hyperplasia, leading to reduced digestive enzyme production, mostly subclinical, sometimes more severe with steatorrhea and malabsorption. This can result in pancreatic exocrine deficiency, insufficiency, impacting the ability to properly digest food. And they can manifest in different ways. They can also manifest pancreatitis. They say to routinely check the fecal elastase level. Sometimes the patient may not have symptoms of exocrine deficiency, but the elastase deficiency will be there. Sometimes they can have steatorrhea worsening the patient's weight. And sometimes the MODY patients also require the pancreatic enzyme replacement therapy. One of the questions asked in the floor when I was discussing this case, why it can't be a mitochondrial diabetes. The mitochondrial diabetes is again called maternally inherited diabetes and deafness. The deafness is one of the important feature of the mitochondrial diabetes. It is characterized by a combination of diabetes and hearing loss, typically inherited maternally. And most common mutation associated with the MIDD is the A32.443G mutation in the tRNA, gene of the mtDNA. This is the treatment I gave. I think I come to the final few slides. I started the guy on glycoside, 30 milligrams twice a day, pioglitazone 15 milligrams, metformin 500 milligrams BD, because I thought the patient has definitely insulin resistance as per the literature. They say even a small amount of insulin, it's got a hepatic insulin resistance, and I thought we can't some of thought metformin, and I also gave him insulin support of Tresiba 15 units at bedtime. After 3 months, the boy's weight increased by 10 kg in 2 months' time. A1 reduced to 6.8 from 16.8. The fasting sugar has come to 104 milligrams, and the PP sugar has come to 164 milligrams. And in fact, there's no pus cells in the urine. This is a guy after you can look at the boy is put on so much of weight. Now he came about 2 weeks back. Now he is 56 kilograms of weight. So really, what he was in a shape and then what he has become now after the treatment, we don't know how long the medicine is going to sustain, but at least we know the diagnosis. We know how to exactly go around in this case, because the precision diagnosis really tells us that these sort of cases should not be missed. Type 1 diabetes, your differential diagnoses are few. Like one of the diabetes is the HNF1 beta MODY 5 diabetes. I think that's my end of the slide. I think we go for discussions. Any doubts from the audience or from the chairpersons, I may like to clarify.
Yeah, I think great case, and I think great success story like our Prime Minister Modi. Yeah. So that way you manage this case brilliantly. I think Khutbu, there is one question left.
The
That is,
last question is what biomarkers or tests beyond GAD antibodies and C-peptide are most likely to help us pick early malnutrition related diabetes?
All of them will be negative, no? GAD will be negative. C-peptide will not be absent. There will be C-peptide. There will not be absent C-peptide in malnutrition and diabetes. That's the one which gives the story. The crux of the story is C-peptide and the insulin antibodies. And of course, the history, as we rightly said, when they come from the background of malnutrition, protein deficiency.
And
Yeah.
in
So
this case, I think metformin and pioglitazone might have helped. What
Yeah.
about glycoside, sulfonylurea? Was there any help from sulfonylurea?
Whatever the beta cells remaining, because it's one of the very soft sulfonylurea. I gave a very small dose to enhance, stimulate the beta cells. So again, showing that still the boy has got some functioning beta cells.
Maybe as a follow-up, you can repeat
Yeah, now he's under my care now. At least now for the past 9 months. He's doing extremely well. He's done exams very well. He has passed all his exams. And he's so much happier. He's able to attend, focus on. He actually came smiling. But I told his father he must have a watch on him. Diet and exercise, they are the main focus. And then frequently check his symptoms and the sugar levels.
now can you stop sharing? I think that no you.
Oh, sure.
So yes. So yeah, Dr. Navneet Agrawal, your comment on this success story.
So this is a wonderful case. In fact, like we see, it is rare cases, not like as Anil Kumar sir was saying that not 5%. If it is less than 1% of Modi, because like we never think of in this way. My another question to Dr. Sundana was like, since there is a involvement of alpha cells in such type of patients, can we use DPP4 inhibitors? Because we know that they also work on the alpha cells.
Yeah.
So if we have the alpha cell involvement, better it would have been like you might have tried, or like any comment on that?
I have not tried DPP4. Now, after seeing the literature, because there's excess glucagon activity, which is one which is triggering the hyperglycemia because inappropriate, we can definitely try DPP4. I think next time when it comes, I thought I'll stop sulfonylurea and give a small dose of DPP4 and see. Probably I'll let you know in about 3 months' time.
Sure, sir. Thank you,
Yeah.
sir. Thank you.
Yeah, Dr. Anil Kumar, your comment here.
Yes, sir. And as we see, it's one of the rarest cases because family history negative requiring very high dose of insulin and having diabetic ketosis, then diagnosing as monogenic diabetes is definitely very rare. So maybe as Dr. Navneet said, you should require strong suspicion.
Yeah.
Because people think that after type 1 diabetes, most of them will be thinking it is type 1 diabetes and treating. And if you have strong suspicion, then they definitely can do genetic analysis. Probably, as we know, Modi HNF 1 alpha is the commonest. So we can do a single gene analysis of Modi HNF 1 gene, 1 alpha. And then depending upon the clinical features like this, if we suspect, we can do other genes. Because as the Modi 3 is the commonest, they say it's about 50 to 60%. I don't know, even in India, it is the commonest. And maybe the next one is the glucokinase gene. We don't see much because they will not come to the doctor at all because they will have very mild fasting hyperglycemia.
Maybe during GDM, they manifest quite a high.
Yeah, GDM, they will manifest. And of course, in GDM, I don't know how many, except for genetic analysis, and we can do.
Especially they have fasting hyperglycemia, one should suspect glucokinase deficiency.
Yeah.
Yeah.
And even I think Dr. Mohan sir's group have detected ABCC8 mutation also, Modi, in India, which is more common. So maybe a strong suspicion is necessary, and more such genetic analysis, if it is done, it will definitely help in precision diabetology.
Yeah, I think we have already crossed our time, but anyway, so one by one, I will ask for the take-home message. So for start from Dr. Khushbu Agrawal, what is the take-home message from this case to our audience?
So my take-home message is that while we just like what Pratap sir was saying, that there was not a single criteria that was being satisfied in the Modi criteria that was originally described in 1975. But once you have exhausted all the other avenues, and if you have a strong genetic suspicion, please go for the genetic testing. At the very least, the patient will have an answer. So just like sir's case, even my case did not have family history. So just absence of strong 3 generational family history should not be the reason not to go for the genetic testing. And I think Sir's case has confirmed that part, that if you have clinical features uh, suggestive of like recurrent urinary tract infection, he had a history of hydronephrosis even as a child. So, and so if you have a strong suspicion, please go for genetic testing, even if there is no family history. So that would be the take-home message from me.
Yeah, so I think Dr. Navneet Agarwal, your take-home message.
So what I feel as a clinician, if you're practicing, if you are feeling that this patient is atypical or unusual, or if you're finding difficult to manage, we should have an eagle's eye and should not think like out of the box. And definitely we should investigate further to find out the cause so that we can manage him properly.
Yeah, great. So Dr. Anil Kumar, your take-home message.
Yeah, as we said, when a patient is diagnosed as type 1 diabetes, he should be regularly followed up. And we should not stamp him as type 1 diabetes. Maybe in future, as we do C-peptide levels, depending upon the response, and if there is persistence of C-peptide levels, definitely you should think of monogenic diabetes and genetic analysis should be done. And as this case, very interesting case with 2 episodes of ketoacidosis, and mostly people think that it is type 1 diabetes, but it turned out to be a monogenic diabetes, HNF1 beta. So definitely we should have a strong suspicion in clinical practice, and then precise diagnosis should be done.
So I think we have came to the end of this case. I think the exciting case. I congratulate Dr. Lakshman for your so much insightful case, and also I think Dr. Mohan Group that he diagnosed in a very I think an early diagnosis was made. And with that, I think I now request Dr. Pratap Jethwani to propose a vote of thanks.
So thank you, Dr. Lakshmanan, for an excellent case, one of the very rare cases, Modi 5. I think this is very rare itself in Modi group, which is quite uncommon in our country.
Yeah.
So this is very rare case which we have discussed, and I thank all the panelists, Dr. Anil Kumar, Dr. Navneet Agarwal, and Dr. Khushbu Agrawal for their excellent insights about this case. And I will just say one take-home message, that any child presenting with hyperglycemia, treat with insulin first. Always keep type 1 as first possibility, but don't forget that other things exist, although they are rare. Whenever there is any atypical clue, like in this patient, the insulin requirement was very high, and at the same time, the C-peptide improved from initial phase to the second phase. There was some improvement in beta cell function, and there was presence of some renal abnormality, which hinted that should be investigated further whether there is some atypicalness is there in this case and should be investigated further. So don't forget, treat with insulin, but always keep that other things are there also in children. It can be type 2, it can be MODY, and it can be this kind of a rare MODY 5, which can be exactly like type 1 with ketosis, with other things, but still it can be MODY. So with that, I thank all of you for joining in. Next month, again, we will come with another interesting case of diabetes, some other aspect related to diabetes. Thank you, everyone. Good night.
Thank you.
Yeah, good night. So thank you, Mayank, also for good technical support.
Thank you,
all.
Mayank.
Thank you. Thank you all. Good night.
Good night.
Thank you.